Hey guys, welcome to Psychologic. My name is Akanksha and I'm your clinical psychology educator. Today we will be starting with module 1. But before starting, I will be telling you how to attempt today's module's mock test. We'll go through it together so you don't need to worry. I'll tell you at the end of this session. So be ready for it. And I hope you all know that the course is focused on specifically preparing you for CUET PG and UGC NET. So, are there any question differences between CUET PG questions and UGC NET questions? Right? Not a lot in terms of the syllabus, but more in terms of how they ask questions. So, CUET PG questions are more direct, more definition based, more authors, years, and age ranges, match the columns. While UGC NET question is more about applying the concept. It's more concept based. How good are you at understanding the concept and applying it? So don't worry, we'll discuss everything properly. So you will be able to apply the concept, and obviously we will be discussing authors, years, age ranges, things like that. So keep your notebook and pen ready so you can take note. Okay, let's see what we are going to cover today first. So today's journey we're going to cover clinical psychology definition, nature and scope, history, roles, training and Indian regulations, mental health professionals, what clinical assessment is, the principles, its process, its goals, clinical interview, MSc, psychological testing, and under that we'll discuss some intelligence tests, personality assessment, and finally case formulation. And then at the end we'll do 5 questions from today's class, and then I'll tell you how to attempt the mock test. So without further ado, let's start. Now, before we get into what clinical psychology is, why did we need clinical psychology as a separate branch of psychology in the first place? Do you think everything that happens, any emotional problem that you face, is a disorder? No, right? Like you're stressed or you're anxious. These are normal human experiences. That does not mean you have a disorder, right? But when these emotional experiences are very intense, it is disabling, it affects your daily functioning, your work, your education. That is when we might consider it as a disorder. So, how did we reach there? We needed a scientific understanding of it. We needed to understand what is happening in a more evidence base. That is where clinical psychology comes in. Like, okay, there's a student, who's struggling in their studies, right? The parents have tried to teach them themselves, the teachers in schools are trying, we have tutors for that child, but nothing is helping. So, is that child just, you'll call that child dumb or lazy? No, right? Or let's just say your friend who used to come to college every day and, used to take part in everything around you, suddenly has lost all its interest. Would you call that, oh, this friend has just gotten lazy? No, right? Or let's say, your sister comes to you and tells you that, I have been hearing voices. Would you say, oh, you're just stupid, you're imagining things? No, right? You can't just jump into conclusions. You need a systematic assessment of it. You need to understand. You need to observe what is happening. That is why clinical psychology came into the picture in the first place. So let's see now what clinical psychology is. Clinical psychology is applying your knowledge. But before just discussing clinical psychology, there is another term, abnormal psychology. So, what is the difference? Clinical psychology, abnormal psychology. Abnormal psychology is studies of abnormal behavior, while clinical psychology is applying that knowledge to assess, to diagnose, to treat, to help individuals. That is what clinical psychology is. So, to understand it, there are 3 major terms from Resnick's definition: science, theory, and practice. 3 important terms, 3 pillars of clinical psychology. What do we understand by these terms? Science. Science means the the field of clinical psychology is evidence based. We don't go about talking about things based on our intuitions. We have scientific methods, we have standardized assessments, we have research evidences to say those things. Okay, so let's see if someone comes and tells you that this I'm feeling very anxious. Does that person has anxiety or anxiety disorder? No. What is happening, how you will understand it, that is science. But why is it happening? That's where theory comes in, right? That anxious behavior, can be explained in a multiple ways. Suppose, a person is having a panic attack. Panic attack can be explained in multiple ways. It can be explained through behavioral theories, cognitive theories, psychoanalytic theories, psychodynamic theories. So different, the same thing can be explained in different manners, different theory. Now, is knowing enough? But just knowing about the theory and the science behind it is not enough. You need to know how to apply it. Okay, let's see. There are two people. Both have the diagnosis of depression. Would you give them the same treatment? Similar, maybe, but same? No, right? Their treatments would differ. And how do you understand what kind of treatment which individual would help that individual more? That is where practice comes in. You practice, you understand, and that is how you learn how to actually apply clinical psychology in real life. Okay, now what does a clinical psychologist do? Therapy, obviously it is one of the part of it, but is it the only part of it? No, right? Therapy is one of the aspects of what clinical psychologists do. Let's start with the first one, assessment. Okay. Assessment is something that truly distinguishes clinical psychology as a profession from all the other professions in the mental health field. How? What does assessment mean? It can have clinical interviews, MSc, observation, psychological testing, case histories. It is basically the backbone of the whole clinical work. Without assessment, you cannot diagnose, you cannot plan interventions, you can even not, decide on what you're gonna proceed with, right? So that is why assessment is the first step as well, and it is the most unique to clinical psychology. Okay, why is it? Because no other professional in the field of mental health does assessment. That is the work of a clinical psychologist. Now, after assessment comes diagnosis. You know, we have taken all the information from them through assessment, right? Now, on based of that assessment, based on a diagnostic criteria, we give a diagnosis. Criteria like what the condition is, that's it. Not how it developed, why it developed. Those things, the case formulation, we'll discuss it at the end. Then comes intervention. Intervention is basically what? Treatment, right? Based on evidential psychological approaches, we have different kinds of treatments like CBT, REBT, family therapy, relaxation training. So, but always remember, assessment comes before diagnosis as well as before intervention. Okay. Then comes the research work. So, clinical psychology is a scientific discipline. You need to understand, evaluate, improve, and advance the field as well. So, that is where research comes in. Then comes consultation. A most confused part is that a clinical psychologist works alone with an individual. No. Clinical psychologists can work with schools, hospitals, rehab centers, NGOs, organizations, even legal systems. Schools can, call up a clinical psychologist and ask them to plan workshops or things like that. That also comes under consultation by a clinical psychologist. Then comes prevention. Clinical psychologist does not just treat problems, but they also try to prevent it. How? Through awareness programs, through stress management techniques, through suicide prevention techniques, and much more than that. Right. And at the end, we come to teaching and supervision. Teaching and supervision, a clinical psychologist teaches students, teaches about the field, and also trains interns, supervises them how to actually, that practice part of it. How do you practice? You practice under someone who has already gained experience in the field. Now, has clinical psychology always existed as a profession? Obviously not, right? In 1460 BC, we have Hippocrates, where ancient Greece. He is also known as the father of medicine. Father of medicine. So Hippocrates is known as the father of medicine. Before Hippocrates, before 1460 BC, any problem, any mental health problem was treated as, oh no, it's punishment, it's a ghost, it's a spirit, things like that. Those beliefs were broken by him. He said that, mental health problems have natural causes and not supernatural causes. And this was a major revolution back then. He gave the theory of four human theory, of, and he proposed 4 humors of bodily fluids based on that. And he said those fluids are blood, yellow bile, black bile, and phlegm. And he said that when the balance between these four bodily fluids is disturbed, then there is some kind of physical or mental illness. Now, you would expect the society to move forward, right? But unfortunately, the society moved backwards. After the proposal of not having any supernatural causes and having natural causes by Hippocrates, unfortunately, during the Middle Ages, we went back to supernatural causes. People again believed that, these problems were witchcraft, possessions, magic, punishment by God, and things like that. But fortunately, you know, during the 1700s, we again started to move further. Okay, how did we move further? We started what? Scientific observation started to take place. Okay, here is where we started scientific observation. Hippocrates was natural causes. Then comes a very important person, 1793, Philip Pennell. Before this, in mental health asylums, okay, these functioned as places where people were not treated as humans, they were literally chained. Okay, and he said that they are not criminals, they have to be treated with compassion, with dignity, they have to be given humane treatment. Okay, so that is where he released these patients and started the moral treatment, and that is how we finally started to have some kinds of ethics in the field. Okay, now something that is commonly mistaken when it comes to clinical psychology is between Wundt and Witmer. Okay, let's understand that. Wundt and Witmer. Wundt is Wilhelm Wundt. He gave, he basically made psychology a scientific discipline. Okay, he opened his first laboratory in Leipzig, Germany. It was an experimental laboratory. Okay, but always remember he opened a laboratory not for treatment, for experiments. Okay, while Witmer came in 1896. Okay, he saw a young boy who was struggling academically, especially with his spelling. Okay, so he did a scientific assessment and planned an intervention to solve a real life problem. That is where there was the birth of clinical psychology as a profession. In 1896, there was birth of clinical psychology as a profession. Okay, but the term clinical psychology came in 1907 by Whitmer itself. Profession 1896, term 1907. Okay. Okay, now clinical psychology has developed as a profession, but how did it become such a large profession? Three major developments happened. Okay, the first milestone was 1905, Binet-Simon intelligence test. That was the first intelligence test that happened. Okay, now second was World War I. Okay, now, how did you decide during the World War that someone should become a soldier or not? Are they even competent to become a soldier? Can they logically think? Can they take the role of the leadership? So the two tests were developed. First, the test was which was developed was Army Alpha. First, Army Alpha was developed, then Army Beta was developed. Army Alpha was for the people who were literate, who can read and write English. Okay, and then came Army Beta for soldiers who cannot read or speak English, fluently and were illiterate. They were also training to be soldiers, right? So we also needed a test for them. So that is where Alpha Beta came in. Another important development that happened was Woodworth Personal Data Sheet. Okay, this is one of the most earliest psychological screening questionnaires. Okay, this is where psychology started to become objective. We have standardized psychological assessments. This became the foundation of clinical psychology. Okay, now world wars have, how much psychological scar you might have, right? So you might have trauma for that, right? So that time that was called shell shock. Okay, which is in the modern days, which we call PTSD. Okay, so there was a huge demand for assessment, for rehabilitation, for treatment, more need of clinical psychologists. So hospitals expanded, veteran services expanded, we developed veterans administration. Okay, and then we needed a proper standard for training this clinical psychologist. So came two models, Boulder model and Vail model. So the first, let's discuss Boulder model. Okay. So a Boulder conference happened in 1949. Okay. This said that a clinical psychologist should be both a scientist as well as a practitioner. An important part to remember is has equal focus, equal focus on research and clinical practice. Okay, and the degree that you needed for that was a PhD, a doctorate, doctorate of philosophy in psychology. Okay, now this a lot of psychologists complain that this has too much focus on research, which leaves very less time to be trained properly in the field. Okay, so came the Vail conference in 1973, which said that we need more focus towards clinical skills, psychotherapy, assessment, and less towards research. So that is why it is called a practitioner scholar model. Yes, there is still research, but comparatively lesser focus. Okay, so always remember older is an PhD, and the newer degree is called PsyD, which is Doctorate of Psychology. Doctorate of Psychology. Okay, this is very important for your UGC net examination, so remember that. Okay, but what about India? This all whatever we discussed was a very Western perspective. What happened in India, right? So for India, the development of clinical psychology was mostly through development of university, hospitals, training organizations, things like that. So the first formal education in psychology in India began in University of Calcutta. Okay, one of the most pioneers of psychology in India was Girinder Shekhar Bose. He founded the founded first Indian Psychoanalytic Society. He was, in consultant with Freud himself, and he founded Indian Psychoanalytic Society. Then came Nimhan's CIP. Okay, what we need to remember is, okay, CIP 1962 began the official training in psychology. This actually was made in 1918 as an asylum. Okay, then came Indian Association of Clinical Psychologists, and right now it has been going stronger and stronger. But it has been going stronger, but how do you become a clinical psychologist in India? One of the major roles that plays is RCI, Rehabilitation Council of India. Okay, they have the responsibility to maintain the quality, to maintain everything regarding that admission, eligibility, everything like that. Now, remember the admission and eligibility criteria changes, through time. The current that we are aware of is you need a 4 years bachelor's in psychology, 2 years RCI recognized master's in clinical psychology, then RCI registration under you have to have a CRR number, Central Rehabilitation Register, and that is how you become a licensed clinical psychologist. Okay. What are the roles? It recognizes professional training programs, maintains the standard, it maintains the CRR, and also decides legally whether you can practice as an independent clinical psychologist or not. Remember always, degree is not equals to license. Just because you have a bachelor's or a master's does not mean that you are licensed. Okay, for licensing you have to do this and get registered under CRR. Okay, now moving forward, these are the 4 premier RCI recognized training institutes right now. There are more, but these are some that I have mentioned: NIMHAN, CIP, LDDIMH, IBHAR. Okay, remember their dates. Okay, and where they are. Okay, let's move forward. Okay, now imagine a friend who is feeling very anxious for several months. They are not able to sleep properly. They do not go to college properly. They have been having panic attacks. Who would you suggest them to consult? Clinical psychologist, counseling psychologist, psychiatrist? The answer is it will be a team effort. They have different training, different responsibilities, but they work together. Okay, let's discuss clinical psychology. Clinical psychologist understands, assess, diagnose, treat using scientific method. They have a major responsibility of assessing. Obviously, assessment can be only done by them. Okay, they have to be registered under RCI. They have to have a CRR. They cannot give you medication. They cannot prescribe medication. Okay, counseling psychologist, more like life difficulties, not the severe psychological disorders, but life difficulties like relationship problems, stress, adjustment issues, grief, self-esteem issues, things like that. Then come psychiatrists. They have a totally different journey altogether. They are medical doctors with MBBS, MD training. Okay, they prescribe medication. They have the ability to diagnose as well as prescribe medication like antidepressants, antipsychotics, anxiolytics, mood stabilizer, things like that. Remember, diagnosis is not prescription. Okay, psychiatrists can do both. Clinical psychologists cannot prescribe. Okay, now the field of mental health does not end there. We also have psychiatric social workers, occupational therapists, mental health nurse, neuropsychiatrists, psychologists, right? Because it is a multidisciplinary field. Okay. Now, when a client says, I am not feeling okay, you directly give a diagnosis. Oh, you have depression. Oh, maybe you have OCD or anxiety. No, right? You do not have enough information, right? A stressed person could be grieving, it could be a burnout issue, or they could have a panic disorder, right? So, before helping the client, we need to understand what the problem is, right? So, that is where clinical assessment comes in. It is a systematic process. It is a systematic process of collecting information, right? Now, how do you collect that information? You have clinical interviews, which is talking to the client where they are presenting their concerns, right? You observe their behavior, how, their posture, eye contact, facial expressions, things like that. Then we have MSc, we'll discuss this later. We have psychological tests, because they are standardized tests, reliable, valid, right? You have case history. Case history is all the information, developmental history, past history, medical history, family history, educational history, occupational history, things like that. And collateral information. Information not only from the patient, but also from friends, uh, peers, teachers, your parents, like that. Okay. Now remember, assessment is broader than testing. Okay, when you go to a doctor and you tell that I have been having, fever for past 5 days, okay, will they say, okay, directly go and get a blood test? No, they'll also ask you questions. Okay, from how many time, how much fever, right? They'll take your temperature. They'll also maybe take your blood pressure. They'll, take your pulse, your heartbeat, things like that. They'll also maybe prescribe more different kinds of tests. So it's a whole process, right? So testing is just a part. It is not the whole assessment. See, psychological test is a part of clinical assessment. Clinical assessment is a whole process. Okay. So what are the principles of clinical assessment, right? Systematic. So you don't just diagnose, right? You don't just diagnose, right? You start with a logical sequence. As we said, it's a proper sequence that you need to follow. You take interviews, you move on to MSc, mostly doing it together. Then you go and do assessments, and together you make, a diagnosis, a treatment, and things like that. Now, multi-method. It means you use different kinds of methods. As I said, you are also taking interview, you're also taking MSc, you're also doing psychological testing. So multi-method, multi-source information from different, people. As we said, teachers, parents, peers, anyone. Okay, it is evidence-based. It is not only based on, personal intuition. So I feel like this. It is scientifically validated. You can't just make a questionnaire at night and, use it to diagnose in the morning, right? It's not empirical. Okay. Now it is a continuous process. What do I mean by continuous process? Is suppose before we started the therapy, I used PHQ-9. Okay, and the first week the score was 20. Now, while the therapy is going on, suppose in the 6th week, I again administer PHQ-9 and the score is 8. Now you can see that there is an improvement. Okay, so this is a continuous process. You're still assessing. It's a whole journey. Okay, and then we have culturally and ethically sensitive. Okay, in one culture, eye contact can be seen as a sign of disrespect, while in the other culture, that could be seen as something that shows your attention and things like that. So, different cultures have different meanings. And ethics, we obviously have to take their consent, maintain confidentiality, respect them, maintain professional boundaries, and things like that. Okay. So, what are the goals? First, we don't just diagnose, we understand what the problem is. You just don't go and say, oh, you have this problem. No, you understand the client, do several, uh, you take interviews and tests, and then you finally move on. Okay. Two people with a same disorder even can have two different life stories, and benefit from two different treatments, right? Secondly, identifying the problem. Now, what is actually causing the distress? What are the symptoms? What are the strengths? What are the productive factors? What are the stresses? We need to know all of this. Third is, after having enough information, that is when we decide, does this information actually meet any kind of diagnostic criteria? Okay. So now that we have taken all the information, we understand the diagnosis, what the diagnosis is, now we decide how to help. Maybe it's a panic disorder and they could be helped using CBT, or maybe they are grieving and counseling would be much more helpful. So that is where you decide that. Then we monitor progress. Okay, you just don't go about with the treatment. You also need to see, is the treatment helping, right? Are the symptoms reducing? Are they still maintained? Are they increasing? So we need to have some kind of understanding of that as well. So we are monitoring that. And the last is, we evaluate the outcomes. In the starting, we set some goals, right? So have you actually met the goal? Has the person improved? Okay. Now, can they still need support or can we terminate, right? So it's a complete assessment cycle. How is it a cycle? You'll see through this clinical assessment process. It's like a roadmap. It's a journey of the clinical assessment. Whatever we discussed till now in proper order. Let's see it through an example. Suppose there's a 24-year-old boy with 3 months. He's facing problem. He's all anxious all the time. He's not able to sleep properly. He's not going to college properly, and he just has this constant nagging feeling that something is gonna go bad. Okay, what do you do? That is his presenting complaint. You take the interview, you ask questions, you know more about this person, okay, why, what happened, maybe something happened 3 months back, okay, what has been the situation, things like that. While doing this interview, you also conduct MSc, which we'll see later. Then we move on to some kind of test. Maybe you use an anxiety rating scale or a personality measurement, or I don't know, depression rating scale, things like that. And then we formulate a case. How do we formulate a case? Again, we learn. Okay, based on those things, now we see if it meets the diagnostic criteria, and based on that diagnosis, we plan the treatment. Okay. Now, as we said, the student, this 24-year-old boy came, he's anxious. You did not just directly administer test or directly, start diagnosis, right? You talk to them. But do you just talk to them? Oh, let's gossip. No, right? Your talking has a clear purpose. Okay? It has a clear purpose. It has a whole system, a whole process. Okay, it's not just a random conversation. It is purposeful, it is systematic. You're trying to understand the person's story. Now, when you're trying to understand the person's story, there's something that is important while doing that. First is building rapport. Building rapport is basically building trust, building that comfort level where that person feels safe enough, comfortable enough to share his or her story, right? You have to be warm. You have to mention that there is no judgment here. Whatever you tell me here, we wouldn't share it with anyone. Your confidentiality is maintained, things like that. Then we gather information. We gather information like presenting complaint. We gather information like history of the present illness. We gather information about their medical history, their family history, their educational history, their occupational history, their social relationships, their present circumstances, their strengths, their coping mechanisms, things like that. And based on these things, that is what guides our clinical decisions that we'll take forward. Now, interviews could be of three types: structured interview, semi structured interview, and unstructured interview. Okay. Structured interview, it's reliable, it's consistent, right? You have fixed questions that you're going to ask, especially beneficial when you have a large number of things to do, right? So it's efficient, it's fast, it's easy to do as well. Moving on to semi-structured, you need to have a guide first of all. What do you mean by a guide? Okay, you have a structure, but you also have flexibility. You have a prompt, but the client is free to go about, go on about that prompt, thing like that. Then is unstructured. That is free flowing conversation. It's open ended, but it's not like unpurposeful. It still has a purpose. Okay. It gives you space. It gives the client the space to understand, to you the space to understand, and the client the space to express. Okay, great. Now let's move on to mental status examination. So when we are doing clinical interview, we don't just listen, we also observe. What do we observe? What we're trying to do is take a screenshot, a snapshot. That is what MSc is. It's a snapshot. It's a snapshot of the current mental functioning, okay? Current state. But is it just random? No, it's not. It's also systematic. It has a proper structure, okay? Remember, it's a snapshot of current, right now. Not past, not future. No personality, no life history. Right now, okay? It is not done separately, it's done during the clinical interview itself, right? It has 8 broad domains: appearance. It starts before even the client starts speaking. The client enters, assessment starts. Okay. Appearance, you will see um, the grooming, the hygiene, things like that. Then we have behavior, we have speech, we have mood, we have thought, we have perception, cognition, insight, and judgment. Okay. Appearance, behavior, speech, mood, effect, thought, and cognition we'll discuss. But before that, perception. Perception is, are there any hallucinations? Perception is what the person is perceiving, something that is not there, and the person has perceived that. Insight and judgment is, insight is, does the person has the understanding of what, why they are here, in the sense that, suppose a client has schizophrenia, do they even understand that they have some kind of um, disorder, or do they have no understanding of it at all? Okay. Judgment is, are they able to make proper judgments, proper decisions, or not? Okay. Now let's come back to appearance and behavior. First is general appearance. General appearance is grooming, hygiene, clothing, facial expressions, eye contact. Okay. So suppose a client comes to you, he's poorly groomed, his hair is all the places, he's extremely tired, right? It gives you a clue that might be related to, I'm not saying it's something, but it might be related to depression. Okay. It adds on to it, right? But suppose a person with mania might have, wear excessive makeup, excessive jewelry, things like that. These are clinical clues. Clinical clues. Okay. Then we have attitude towards examiner. Are they cooperative? Are they friendly? Are they very guarded, very suspicious, very hostile? So these things also give you an idea. Maybe they're very paranoid. Schizophrenic people are very paranoid. Okay, so very suspicious, very guarded. Okay. So now the third is comprehension. Are they even understanding what you're saying, what you're asking? So that is a comprehension comes in. Gait and postural. How are they sitting? Are they slouched? Are they just rigid? Are they, stifling? Are they just stooped like this? These things matter in understanding, right? A depressed person is usually very slow, very slouched, while in a Parkinson's person, you can see that they have a very stifling gait. They can't just be like this or that. They just try to adjust a lot. Then you have motor activity. Again, what is the movement? Are they restless, agitated? They have tremors. They have agitation. They are fidgeting, things like that. It reflects their emotional as well as their neurological state. Okay. Again, as I said, maybe they're restless, right? So that could indicate a lot of things. Maybe a child with ADHD might be restless. Okay. At the same time, as we said, a person suffering from Parkinson might have tremors. Okay. So that is how you can judge. Then we have social manner. How appropriate is their social behavior? Are they very polite? Are they overly friendly to you? Are they extremely withdrawn? Are they very inappropriate with you? So things like that also give you clues. And then we have rapport. Have you built that trust? Have you built that environment where they are comfortable enough to share things with you? Okay, great. Then let's move on to speech. It's not only about what you see, it's also about what they're saying, right? But not only what they are saying, how they say it. How they say it. Okay, so speech is something that you can directly observe, right? So you observe it in three manner. First is weight and quality. Is the speech slow, rapid, very pressurized, very hesitant? Okay, a person with depression might sound very slow to you, while a person with mania, their voice has this pressured feeling. Okay, so things like that. Then we have volume and tone. Volume and tone is it very, they're speaking very softly, very loud, very monotonous. Okay, very emotional. It'll also give you an idea of their emotional state. Then flow and rhythm. Is it logical? Is it tangential? Is it very is it organized or not? things like that. Okay. While are they speaking, when they're speaking, is there a rhythm to it? Are they speaking just or things like that matter? Okay. So it's how the speech flows, but not the what they're thinking. How? Just the flow of the speech. Then we have thought. That is where something that is not directly observable, but we observe through the speech, right? So it has stream and form and content. What do you mean by stream and form? Stream and form is how organized or express the content is. Okay. While when we talk about content, it's like what the client is talking about. It could be a delusion, oppression. You can see what the client is talking about is hopelessness, worthlessness, suicidal ideations, things like that. These two terms are often confused, so there is this slide where MSc confusion busters. We'll clear this up there. Okay. Now in cognition, let's start with consciousness. Are they alert and awake? That is what you're asking here. Orientation, time. Are they oriented to time? Do they know what time it is? Are they oriented to the place? Do they know where they are? Are they oriented to the person? Do they know who they are? And are they oriented to the situation? Do they know what is happening around them? Okay. Attention. Are they able to focus initially? Right? If you call their name, that focus. And then concentration, are they able to sustain that focus? I'm talking to you, talking to you, talking to you. Are you able to concentrate? Are you able to focus for a longer period of time? In memory, what we are checking, their immediate memory, their recent memory, and their remote memory. Like recent could be what they had for breakfast, remote could be some story from their childhood, and immediate could be you can just ask them what you just said, things like that. Intelligence, we are not doing a proper IQ assessment here, but just a clinical idea of um, what their intelligence level would be. Okay, and then abstract thinking. Abstract thinking is not something concrete that I'm just saying. Okay, it's more um like a proverb. Suppose I say, don't judge a book by its cover. So do you just say, okay, I'm seeing the book and I'm not supposed to judge it, the cover? No, it means that don't just look at someone and judge their whole personality, right? So that's an abstract thought. Are they able to understand that thing? Okay. Now, as I said, there are two topics that is extremely confusing and extremely a lot asked is these two confusing topics, mood versus affect and thought form versus thought content. Okay. So let's just understand mood versus affect. Um, I have been feeling very sad for the past month. This is what a client comes to you and says to you. What is this? This is mood. Mood is told to you by the client. It is subjective in nature. Okay. Now I say as a clinical psychologist that I according to my observation, his expression was extremely flat and a very little emotional expression was there. What is that? That is affect. That is the observation by the clinician. It is objective in nature. So mood is subjective, it is by the client. Affect is objective and it is by the clinician. Always remember that. Now, let's move on to thought form versus thought content. Suppose I say I'm reading a book. How the book is written, okay, that's the organization of the book, the expression, that is the form, thought form. But what the story is about, that is the content. It could seem like a delusion, guilt thought, suicidal thought in the client. Okay, so suppose someone comes and tells to you, my neighbor spies on me. Okay. Is it a thought form or thought content? It's a thought content. So, with this, remember these two, and with this, we are done with mental status examination. Now that we are done with mental status examination and interview, now we have a clinical impression of the client. But that is subjective in nature. We need something objective, something standardized, some kind of evidence to support what we understood. Okay, that is where psychological testing comes into the picture. Three words: standardize, measure, and specific. Standardized means it has to be, reliable and it has to be validated. If I'm using the same test again and again and again, it shouldn't give different results. Okay, and it should test what it is supposed to test. That is standardized. Measure it measures something, right? It is measuring some kind of thing. It could measure personality, it could measure some kind of symptom for depression, for anxiety, something. Why did we use the term specific? A test does not measure everything, right? It measures something specific. A test could measure, uh, maybe a test could measure anxiety, or a test could measure um, depression, but there are different tests. Every test is specific to something. Okay. Now there are different types of tests. That's why first we have intelligence tests. They measure your cognitive ability. Like we have WAIS, we have Stanford Binet, things like that. Then we have personality tests. They measure your personality traits, and they can also measure psychopathic tendencies. Right? We have MMPI, we have NEO, we have 16PF, and many other tests. Then developmental tests. They are usually done for children to assess their developmental milestones. Neuropsychological tests, it is, to measure your brain functioning, your behavior tendencies, right? It is especially done after a brain injury or a stroke or some kind of neurological disorder. And then symptom rating scale. They measure the severity of any kind of disorder, like, HAM-A, we have HAM-D, we have BDI. So psychological testing is one piece of the puzzle, and clinical interview was one piece of the puzzle, MSc was one piece of the puzzle. These total together, all of these come together to make a whole picture, right? Now, intelligence assessment. Intelligence assessments, so we are discussing specifically here some of the tests given by David Wechsler. Okay, we have WPPSI, Wechsler Preschool and Primary Scale of Intelligence, WISC, Wechsler Intelligence Scale for Children, WAIS, Wechsler Adult Intelligence Scale, and you need to know the major indices for the the most current WAIS, and also the evolution of WAIS and evolution of WISC. Take a screenshot of it, okay, and remember these information. These are constantly asked. You also have to do some other tests. So MISIC is an Indian test, okay, most standardized Indian test. It is an adaptation of WISC. It is mostly used for children in India. Okay. Bhatia battery test. Bhatia battery test is largely non-verbal, very famously used again in India because it is cultural specific. Then RPM. It is culture pair test. Why is it culture pair test? Because it is non-verbal. And then what does it measure? Fluid intelligence. These are important pointers. Remember that. RPM has three types: PPM, SPM, and APM. PPM is colored progressive matrices. SPM is standard progressive matrices. APM is advanced progressive matrices. Colored progressive matrices are for children. SPM standard is for general population, and advanced is for above average population, gifted population. Okay. Now move on to personality assessment. So again, for personality assessment, two things that you need to remember is objective test and projective test. Projective test. Okay. Objective tests are fixed, they're standardized, they have a proper structure, and they're quantitative in nature. So they're easy to score as well. Okay. Objective tests, some of the objective tests are MMPI, NEO-PIR, 16PS, EPQ. Okay. While projective tests is more subjective in nature. They have ambiguous stimuli. Okay. Maybe they'll show you some cards and ask you to interpret, you'll say what you see and then they'll interpret that. So it is qualitative in nature as well. Like Rorschach, Inglot test, CAT, house street person test, job person test, and many more, right? So again, you need to remember these, take a screenshot, remember this information, very frequently asked. Now let's move on to a very important topic, which is case formulation. So when you make a diagnosis, what does a diagnosis tell you? A diagnosis tells you what the disorder is. What the disorder is. It does not tell you why it developed, what maintains it, what triggered it, and what factors will help you in the recovery. That is what is case formulation. That is what the case formulation tells you. That is what the 4Ps model is about. So the predisposing factors talks about what actually, increases the vulnerability, what actually made you vulnerable to the disorder itself. It could be, a genetic, you inherited it genetically. It could be a childhood trauma. It could be just your personality, or it could be some kind of history, right? So those are predisposing factors. The next is precipitating factors. What actually triggered the current state? Okay, how that you reach to that state, that is what is precipitating factors. It could be a breakup, it could be job loss, it could be you failed in an exam. Then we have perpetuating factors. Perpetuating factors are factors that maintains that problem. Okay. What is keeping this problem going? It could be a very abusive household. It could be substance abuse. It could be your negative thinking, things like that. Then we have perpetuating factors. Perpetuating factors are factors that they are your strength. They are your good, positive parts that strengthen, that support your recovery. It could be having family support. It could be insight to the disorder itself. It could be good motivation. It could be good coping skills, things like that. Now, how is this based on? This is also based on biopsychosocial model. So it's your biological factors, psychological factors, social factors coming together. It's not one single cause. So suppose a, a person suffering from depression, maybe their family has a history of depression, and then you failed an exam. Okay. Then you were keeping yourself isolated, just thinking negatively and negatively and negatively. And then now you are in recovery. So you have very supportive parents and you're very supportive friends. So that would become your perpetuating factor. So that is how this whole thing works. Okay. So take a screenshot of this as well. These are one of the most common clinical diagnostic interviews that you need to know and is very frequent in exam: KID, mini, CD, and CAN. Okay, take a screenshot of it and also take a screenshot of this common clinical rating scale. Okay, um, we will discuss these with the disorders itself. For now, just take this as a reference table and take a screenshot of it. Okay, now that we are done with our module 1, let's check what you have actually learned. So first, who established the first psychological clinic, marking the birth of clinical psychology as a profession? Just, pause the video, answer it, and then you can hear me telling you the answer. Okay, pause it, answer it yourself. It's okay if you're not able to answer as well. Great if you do. Okay, it's just you need a little bit of revision. Look into your notes. It will be very helpful. Okay. So who established the first psychological clinic, marking the birth of clinical psychology as a profession? Leitner, Witmer. Okay, great. Okay, second question. A client reports feeling sad but smiles throughout the interview and laughs while discussing distressing events. Which MSP finding is most appropriate? A. Depressed mood with congruent affect. B. Euthemic mood with appropriate affect. C. Depressed mood with incongruent affect. And D. Elated mood with restricted affect. Okay, the answer would be C. Depressed mood, because mood is by the client and incongruent affect is by the clinician, right? Objective and subjective. Okay. Third is, which intelligence test is specifically designed for preschool aged children? A. WAIS-IV, B. WISC-V, C. WPPSI-IV, and D. MISIC. The answer would be WPPSI-IV. Remember the word specifically. Yes, MISIC can be used, but specifically designed for it is WPPSI-IV. Fourth question. Mullin's Intelligence Scale for Indian Children is an Indian adaptation of which test? A. Stanford Binet, B. RPM, C. WISC, and D. Bhatia Battery. Exactly, it is an adaptation of WISC. And fifth, a client has a family history of depression, develops symptoms after losing a job, continues to isolate socially, but has a strong family support. Which of the following is correctly matched? Job loss predisposing factor, social isolation protective factor, family support perpetuating factor, family history predisposing factor. The answer is D, family history predisposing factor. Okay, so has a family history of depression would be predisposing factor, making you vulnerable, develop symptoms after losing a job. It triggered it. That would be perpetuating factor. See here. Oh, sorry, precipitating factor. Sorry, precipitating factor, right? And continue to social isolate socially. It would be your perpetuating factor. And then strong family support would be your protective factor. Okay. Okay, I have given the answers here as well for your reference. You can take a screenshot if you want. Now let's discuss the actual mock test given by Psychologic that you can attempt. So a link has been attached with the video. You can go and open that link and it will have fields like name and email address. That's it. You will not need any kind of test code as it is the first mock test. So enter your name, enter the email address, right? Okay, and then you'll get, click on submit and then you'll get the question. Okay, you'll get 50 questions with timer, attempt those questions, see your results and gauge what you have understood, what you have learned, what you're not able to answer. It's okay, go and revise that and be confident. And I hope that you understood this module properly. Okay, now go and attempt the mock test. So I hope to see you again for module 2. Till then, bye bye, take care.